All right, so I'm going to put us in the center of the table, lean over, so we're understood, we're heard. You can speak up. Beginning our case discussion of Donnie Darko. Let's arbitrarily agree that we're going to start with Donnie. Fine. Without really getting into the clinical aspect of this movie, watching this movie and discussing this movie like a non-psychiatrist or somebody who's not in their psychiatry clerkship, what did you see that interested you pertaining to the main character?
Well, definitely the fact that he sees a giant rabbit named Frank. He's also one to sleepwalk, which I guess kind of leads to all these different events that kind of happen. Because I guess the first time he really ran into his friend the rabbit, he was sleepwalking, and then I think the rabbit is the one that told him that the world was going to end. So I would say Donnie is like a little bit of maybe like a loner kind of, and even his name, Donnie Darko.
Mm-hmm. Matter of fact, Gretchen brings that up.
Yeah.
You know, what kind of name is that?
Yeah.
She said we do kind of some kind of superhero or something, right?
Yeah.
It's a bit of a loner, and I'm going to put Gretchen. So we have a third person account, a collateral individual providing that information as well. Her name is Gretchen. All right. Anything else that anybody? I mean, we have an hour for this, so there's a lot of time to discuss anything anybody wants. So let's start with these three. Sleepwalking first. All right. So any thoughts about maybe Donnie Darko is a case study? The film is a fictional case study of a sleep-wake disorder, sleepwalking, which would be a parasomnia, abnormal behavior at or around the time of sleep. Anything to support or perhaps go against this provisional diagnosis?
Certainly visions at like night, again, like right around sleep time. I mean, granted, he does have these pieces throughout the day, but I'm interested in the idea that like right before sleep, waking up, there's definitely some visual disturbances that could link or corroborate some of the other pieces we're talking about.
Yeah, you know, if we're going to tie in him seeing Frank, and we look at visual hallucinations in the field of psychiatry, very quickly we should be reminded that that modality, vision, with regard to perceptual disturbances, is often organic versus due to a mental disorder. And organic means either due to the direct and physiologic, emphasis on physiologic effects of a substance or an underlying medical condition. All right, so first and foremost, is there any indication that Donnie Darko uses or abuses a substance? And let me just kind of restate this. Is there discrete evidence in the script of this film that supports Donnie Darko is using a substance?
Like high school partying, for example, and pieces. Just hanging out with his friends before and like shooting bottles and alcohol and everything. Like there's all these pieces touched upon.
So in terms of discrete evidence, actually in the script, alcohol, right? Can alcohol induce psychosis? And if so, how? And I will prompt you. There are actually three answers here. So three ways in which alcohol may induce psychosis.
Is it the withdrawal from it? Then?
Alcohol withdrawal. That's one. Two more.
Is it alcohol compounded with another substance?
That's cheating. No.
Okay.
The answer is that yes, very often in clinical practice, but not for purposes of this academic discussion. Let's focus really on the physiologic effect of alcohol.
Alcoholic hallucinosis?
Withdrawal. Yep. So withdrawal comes in two basic varieties: uncomplicated and complicated. Complicated withdrawal states usually have two examples, or depending on how you look at it, three examples that routinely come up on exams. They could either be manifest as seizures, otherwise known as alcohol withdrawal seizures, or perceptual disturbances. Right? The perceptual disturbances themselves have two examples: alcohol-induced delirium, or I should say alcohol withdrawal delirium, and alcoholic hallucinosis. Both are examples of perceptual disturbances. Both are discrete diagnoses in the DSM, branching off, evolving from alcohol withdrawal, specifically complicated withdrawal. Right? So seizures and then perceptual disturbances, including delirium and alcoholic hallucinosis. Now, a person presents with established alcohol use disorder. They tell you per their self-report that they average 2 cases of beer and quote unquote multiple shots of whiskey a day. And approximately 24 hours ago, they've abruptly discontinued their intake of alcohol. They present to you with signs and symptoms that are highly suggestive and diagnostic of alcohol withdrawal, one of which is that they believe there are spiders coming out of the wall. They see them. Organic pathology, alcohol withdrawal. What's the next question you want to ask then to differentiate the perceptual disturbance of alcoholic hallucinosis from that of alcohol withdrawal delirium? Because you can see things in both cases. Orientation. If they are disoriented, they are likely delirious. The individual with alcoholic hallucinosis has a clear sensorium. Hopefully they will sound like I am, or at least I'm trying to sound to you. In that case, when such an individual reports to you that they are seeing things, it's more likely alcoholic hallucinosis. Now, the differentiation is important because that individual may be able to be transferred to a floor when you admit them, whereas the individual with alcohol withdrawal delirium should go to the unit, right? So you should know that.
What do you mean when you say the unit? Like
MICU.
MIC, okay.
One more example, well, 2 more. We said, so alcohol withdrawal, specifically complicated withdrawal, may induce psychosis through these perceptual disturbances. What 2 other ways might alcohol induce psychosis other than withdrawal?
Intoxication.
Good, yeah. I mean, alcohol by content may be strong enough where drinking alcohol and becoming intoxicated can result in psychosis. Fortunately or unfortunately, depending how you look at it, since it's a fictional case, we'll say, unfortunately, Donnie seems to only be drinking beer. And that's not going to have the proof, the alcohol by content, that would suggest it being an etiology to his seeing a giant bunny that is telling him the world is about to end, 28 days plus.
Is there any consideration to the amount? I mean, I know there's proof, but like the quantity necessary to potentially hallucinate.
I honestly think that the alcohol by content in beer, an average beer, is such that no amount. I mean,
Sure.
I think the fluid is more likely to result in hyponatremia that then will cause delirium, psychosis, before the actual alcohol content does when it comes to beer. All right, one more way. The answer is the chronic ingestion of alcohol over time may lead to B vitamin deficiency and a Wernicke-Korsakoff syndrome. Now, I'm splitting hairs here. We would not call that a true alcohol-induced psychosis. That is actually psychosis due to a general medical condition, specifically thiamine deficiency, that itself was brought upon by chronic alcohol use. So whether or not you look at it as a true substance-induced psychosis or that due to a medical condition, specifically thiamine deficiency, is up to the clinician. But that is another way that alcohol would be involved in the pathogenesis of psychosis. Those are the 3 ways. Donnie, 17, 18, not likely Wernicke's-Korsakoff. He's drinking beer. So the only thing we can suggest as a clinician, if alcohol were to be playing a role, is that this is due to withdrawal. Is Donnie Darko the film? fictional case study of a complicated alcohol withdrawal syndrome?
There would have to be like so much alcohol drinking, like off scene, off script, in order to support that point.
That's fine. Might there be another reason, though, that even if we were to consider this, it would be extremely low in our differential?
No tremors.
Yeah, there's no,
delirium.
right? I mean, even if we do identify that Donnie Darko is struggling with psychosis, and I believe he is, it's really going to be hard to make the case that his psychosis is in the context of withdrawal when he demonstrates no other signs of or symptoms of withdrawal. So, not likely here. The next question, though, which should come right after that initial, is despite the fact that there is no discrete evidence in the script, should the clinician be reassured then that substances are not playing a role in the pathogenesis of Donnie Darko's psychosis? And the answer is always no, right? Because we always want to maintain a high clinical index of suspicion, irrespective of age. So we're going to, and to your point, he is hanging out with friends, and we don't know what they're using. Even if it's not discreetly in the script, you better maintain that high clinical index, because if you were not, you do not want to end up. That is, if you do not maintain that high clinical index of suspicion, you do not want to end up with what we would call a false negative, because that would do harm to your patient. So let's keep it on a differential, albeit somewhat low, but we're going to keep it in nonetheless. Is Donnie Darko the film a fictional case study of a psychosis that is due to an underlying medical condition? So again, it's in two questions. Is there discrete evidence in the script to suggest that Donnie Darko is afflicted with a medical or neurological condition? None. Follow-up question. Despite the absence of discrete evidence, should the clinician be reassured that therefore Donnie Darko the film is not a case study of psychosis due to an underlying medical condition? And the answer is no. And here we can talk a little bit about those risk factors. Again, females are simply healthier than males, and younger individuals are simply healthier than older. And he seems to be in the intermediate category, right? He's a young male. So in the intermediate category, the conservative physician will leave him in the differential. The more laid back, leisure, whatever adjective you want to use, physician may actually say there's nothing here. Right? We'll be conservative, right? We'll keep him in because he is in that intermediate, and I don't see him going to a primary care physician. So until he does, I'm going to leave him in our differential, albeit low. So here we are. Now, the sleep-wake disorders, kind of very similar to the neurocognitive disorders, operate in a gray area in the DSM. They operate in a very gray area for the American Psychiatric Association because they are not true mental disorders. On the other hand, they are published in the DSM nonetheless. So organicity does count when we talk about the sleep-wake disorders. So they are, and they should be, at least gain a perspective of being a general medical condition, even though they're considered to be a mental disorder by the American Psychiatric Association. They're both, as are the major neurocognitive disorders like Alzheimer's disease. Right? So this one we have to keep in, and this does prompt a discussion of the sleep-wake disorders, both the dysomnias, that is the dysregulation of the sleep architecture, the actual physiology of sleep, as well as the parasomnias, abnormal behaviors at or around the time of sleep, including but not limited to sleepwalking. So we've got to keep them in as well. Similar to what I said with regard to Donnie better get to a PCP before I'm reassured, so too then should he go for a polysomnography. Right? Now there's a little bit more to this with regard to, actually two points I want to make with regard to sleep-wake disorders pertaining to Donnie Darko before we move on. Number one is, with the signs that he presents with, and because narcolepsy, I think, is in the discussion, on your shelf exam, on an exam, you may have have to look at the next best step, and the word polysomnography may not be in your answer set. What is the specific type of sleep study that you would refer somebody like Donnie to when you suspect narcolepsy?
Is it at a specific sleep center that they need to monitor?
I think most sleep centers would have this at its disposal. It's called a multiple sleep latency test. It's rather nihilistic when you describe it, but when you understand the pathophys of narcolepsy, it makes a ton of sense. Narcolepsy is a condition in which there is REM intrusion into non-REM states. So individuals, when they're awake and alert, REM, meaning that they have sleep paralysis, they have cataplexy, and they have active dreaming as evidenced by visual hallucinations. To discover whether or not individuals are REMing during non-REM states, we apply the multiple sleep latency test where the individual is admitted to that sleep lab, and after 15 minutes of restful sleep, they're woken up by the sleep tech. And then they're allowed to go back to sleep, and then 15 minutes later, they're woken up again. And this happens for hours.
So for diagnosing narcolepsy, I know there are home studies, so home study wouldn't be able to diagnose someone with narcolepsy. The person would have to go to the center specifically.
So, to my knowledge, I think you have to actually go to a sleep center and actually undergo an MSLT. Now, I see in the textbooks that as a surrogate that for lack of a better word, routine polysomnography has been used as well. But I could tell you that on shelf exams, on exams, the MSLT is the single best answer. It's that specific test where individuals are provided multiple 15-minute naps. For us, none of us would ever get REM. 15 minutes is just too short to get into REM sleep, right? It's too short to go through stages 1, 2, 3, and 4 of non-REM and enter into REM. If you do, I think it's more than 50% of the time, it's pathologic. Right, so people should not be entering into REM within the 15-minute time frame of one of those sleep latencies. So that's the test you would order here. All right, so I definitely want to cover that. There was one other thing I wanted to discuss. It escapes me right now, but we'll come back to it pertaining to narcolepsy and Donnie Darko. Oh, yeah, the other parallel, I'm sorry.
I just have a quick question about the latency test. So then if somebody is narcoleptic, they are entering into REM? Or,
Correct.
so in those 15 minutes? Okay.
It's pathological to enter into REM so quickly, right? And that pathology is called narcolepsy. The other thing I did want to mention is that what we now look as a possibility of sleepwalking, perhaps in the context of another sleep-wake disorder, rule out narcolepsy. If you've looked at the director's cut of this movie, you know there's a whole heck of a lot more going on with Donnie Darko than meets the eye, especially the clinician's eye. And we're going to talk about that, right? We're going to talk about all this differential diagnosis, and then we're going to absolutely just, overturn the apple cart and go in a completely different direction as per the director. In a very similar way, we also understand that another very infamous case study of sleepwalking is not what it appears to be either, and that's Macbeth. Right? The whole world understands the iconic scene in that play as Lady Macbeth sleepwalking. However, when you actually take a closer look at what's going on, it's delirium. So a bit of a 1-2 sidestep and a nice parallel between parallel universe between Donnie Darko and, of all things, Shakespeare's Macbeth. Both, maybe at the surface, appear to be about sleepwalking, or at least incorporate sleepwalking, and neither is the case in each of those films. Lady Macbeth, it's delirium. Donnie Darko, I'm not going to tell you what it is. We're going to actually get to that a little later. All right, so the loner. I put up that he's a loner. Unfortunately, we don't have Donnie Darko, the prequel, So we don't know a lot about his history. Of course, anything that we glean with regard to his past and developmental history are or will be taken from scenes in the movie itself. And we can deduce maybe what's going on or what we may want to know more about. That said, certainly when you use the word loner, I think you used the word loner, in psychiatry, that will always prompt a cluster A personality disorder. And to the extent that we may think that Donnie Darko, the film, is a fictional case of a first break psychosis, rule out schizophrenia, well then we should be talking about the cluster A personality disorders because they are prodromal, right? They are thought to be part of the biopsychosocial factors that pose risk of developing a condition such as schizophrenia. Of course, if we're going to talk about the cluster A personality disorders, we're talking about the psychological factors, that is, the psychological part of that biopsychosocial model. So let's talk about this. If you were to write the prequel, and I assigned you to ensure that the script was evidence-based and therefore should contain aspects of the paranoid personality disorder, what are some of the things you would attribute to Donnie, the character, in writing that prequel?
Just as a kid, let's say in elementary school, evidence that things he either leaves at school or misplaces that's obvious to the camera, but then later him having conversations to the teacher like, I think someone stole this, or like, I saw someone looking through my stuff the other day, when, again, seeing confirms that's not the case.
Right. So misattributions, feeling persecuted. The general idea, the cardinal trait, would be a very pervasive, so not only as teacher, but we would hope to see this behavior at home too. Pervasive suspiciousness of others, right, in terms of displacing blame. And what defense mechanism is likely underlying that major attribute of the paranoid personality? Projection.
Yeah.
Right? Projection. Projection is just that. It is a misattribution of one's impulse onto another. So it is much safer for an individual to say, you hate me, or my teacher hates me, rather than to admit, I hate them. Right? Because if they have the impulse of hating someone, that impulse is going to be embedded in Donnie Darko's id. I hate them. I hate my teacher. I hate the inspirational speaker. Okay. As that's coming up to conscious awareness, it's going to be thwarted. And it's going to be thwarted by the superego because Donnie's parents have taught him that's not nice. So that's going to raise conflict. Right? The id is that base desire. I hate my teacher. The superego is going to prohibit that from coming to conscious awareness because it's way too threatening. Mom and dad, parental extenders have taught me, you shouldn't think like that. This conflict results in anxiety. The anxiety will be alleviated by the ego, that third and final component of one's personality, through the ego defense mechanisms. And if projection happens to be the defense mechanism employed, and it is the characteristic defense employed by individuals who have the paranoid personality disorder, and therefore those who are afflicted with schizophrenia. Those feelings, those impulses will always be misattributed to other people, resulting in a pervasive suspiciousness of others. So that's what's going on here. Now, then the question comes in your prequel. If this were to be a movie, the prequel, about the paranoid personality disorder, we would have to kind of get at what his developmental history was like so as to why he had those impulses to hate different people or have it in for different people. Where's that coming from? There's no answer here, of course, but that would build a character in your prequel. On the other hand, if we decided the prequel to be about the schizoid personality, now, individuals with paranoid personality disorder can be loners as a result of their suspiciousness. They don't trust people. And that pervasive mistrust results in them being isolated. So it's a result of that cardinal trait. The schizoid personality. You're gonna make a prequel, And in this prequel, he has the schizoid personality. Now describe your character, young Donnie.
Maybe doesn't go out of his way to make friends in school, avoids going to, birthday parties, parks with his friends, any sort of social interaction, kind of keeps to himself more, maybe plays a lot of video games, maybe he does a lot of things that kind of keep him excluded from other people.
Agree. And as he is avoiding other people, two things I want to address here that I think need to make your script, and please help her out. Number one is, what's the level of conflict with regard to Donnie's isolating? On a scale of 0 to 10, 10 being incredibly conflicted versus 0, no, not in conflict at all.
I would say closer to 0. I think he would prefer being schizoid.
Good. Right? Yep, that's exactly right. Now, for test-taking purposes, you should know that individuals with a schizoid personality rarely come to clinical attention, and they rarely are self-referred. So if an individual were to present to clinical attention, it's usually through a third party. In Donnie's case, it would be his parents, right? Sometimes a health inspector might, for an adult on a shelf exam, right? So that's a little test-taking pearl. When Donnie is isolating, when he's a loner in your movie, in your prequel, we also need to make sure that we go beyond just kind of focusing on what he's avoiding, and just as much, what is he engaging in? So we got the easy part down, right? Half the movie's done, he's avoiding, but we want to make money here. So if we're going to bring people to the proverbial theater once our theaters open up again, what in fact will we have Donnie doing if he's not doing the stuff that would be more age appropriate?
I'd like to think if we want to connect it to Donnie Darko the movie, like creating his own stories or imagining things that are going on in his life, like maybe he's an intensive drawer or creates these fantastical scenes. I know that's more schizotypal, but I like the idea of it being the two because certainly it gets even more fantastical by the time we hit the movie.
That is actually defining of the schizoid. The idea here is that the individual, a young Donnie, will create this fictional universe that is an autistic retreat into a fantasy realm, so as to act as a buffer between him and the real world, and therefore the anxieties of the real world. Yes, so we'll see a withdrawn Donnie. Now, the social withdrawal here is different from that of paranoia, which is prompted by that pervasive suspiciousness. This is much different. This is the result of a defense mechanism called fantasy.
Could we argue that then this Donnie that he sees is one of these kind of fantastical, maybe, workings of his mind?
Exactly right. And this is where you'll have to determine how you choose to gain that perspective. Is the writer-director showing us a visual hallucination, or are we seeing into Donnie's mind and have this giant bunny rabbit really be his imaginary friend? And there's no answer. It is going to be up to the viewer. And that perspective you take is going to go a long way in ultimately deciding what this movie is really about. And if we take this back to the prequel, let's make Donnie 4 or 5 years old. And let's make Donnie, a 5-year-old Donnie, tell his mom or dad, I'm sorry, I'm sorry. When he's scolded for being late coming down for dinner because his parents have been calling him, what have you been doing up there? I've been talking to Frank. At that point, what comes into your mind as a clinician watching this movie? Good, nothing. Good, nothing, right? Normal behavior, choice A on the shelf exam, choice A on the test, right? Age appropriate behavior. Imaginary friends are fine, right? Now, again, if Donnie contributed more information that kind of gets outside of that realm, so be it. But if a young Donnie Darko at age 4 tells his parents that he was late to dinner because he was talking to Frank, at that point, There is no pathology. This is age-appropriate behavior. This is fantasy play. Similarly, if you walked into Donnie Darko's room, right, or his sister's room, it could be either child, and they're having a tea party. Right? Most children who have tea parties are talking to their guests, and guess what? In those little teacups, there's nothing in there. As a parent, you'll discover that, and you'll sit down for a while, and you'll have these tea parties with your children. At 4, I hope that once you finish your tea party, you don't call me for an urgent psychiatric assessment. This is normal behavior, and that holds true in a young Donnie as well. So this is fantasy play, right? And fantasy play comes from that unconscious or subconscious defense, that process of the ego, aptly named fantasy. Now, of course, when a 5-year-old Donnie is experiencing this and is relating this to his parents, we will react to that differently than a 17 or 18-year-old Donnie who's having the same experiences, because then it is not age appropriate.
I have a question about that. So I've always seen it as like it's age appropriate while school age. I'm in school. It wouldn't be appropriate. What's that age?
Yeah, so that age is probably around 5 or 6. To get the real number, we should pass that by one of our child psychiatrists just to make sure I'm accurate.
Okay.
But I'm guessing around 5 or 6 years of age. It has less to do with school and more to do with the individual going from a total dependent state, that is, someone who is completely dependent biopsychosocially on their parents, primary caregivers, to a state of independence. That transition does not happen overnight. Right? The individual, the child, will push the ticket to see how far they can get. At some point, they'll be told no. And they know that's where they're going to stop that day or that minute. And they'll behave to push the ticket again. It starts at 2 years of age, right? The terrible twos. That's that process of individuation. Right? That doesn't take place overnight. There's a transitional period. And there are multiple ways to cope with the anxiety of trying to straddle that line between, I love being dependent because I love everything that's always handed to me, but I also want to be autonomous as well. And when that anxiety comes up, individuals will have to find means to self-soothe, hence the defense mechanisms. Other than fantasy, which is, of course, one of those defense mechanisms that helps in that self-soothing, there's another one called animism. What is animism as a defense mechanism? And give me an example of it in this scenario.
It's the idea of looking part of personality or like human characteristics to objects or animals.
Excellent. And give me an example of a child who is 4 or 5 and during this transitional period.
The blanket like starts to have feelings.
Yeah. Blanket, teddy bear. Yeah.
I was just watching Noah Holmes on Netflix, and she has like a little pine cone that she turns into.
Pine cone. Yep. Haven't gotten far there yet, so no spoilers. Yep. Right. So animism is another example of that self-soothing. By the way, any object that provides that in this transitional period is called the transitional object. Right. That's a Winnicott term. Transitional object. Winnicott is the theorist. So maybe that's our prequel. Maybe we see a young Donnie, maybe initially, beginning of the movie, age-appropriate behavior, but then certainly, flash on the screen 2 years later, 5 years later, but engaging in the same behavior. And this would certainly be consistent with the schizoid personality. The schizoid is basically an accelerated age that still portrays or demonstrates that type of behavior. Fantasy is the defense mechanism that becomes maladaptive, that then defines the schizoid personality disorder. Now, think about it as linear here. That is, the individual may evolve, doesn't always happen like this, of course, but they may evolve from schizoid, and that all the subconscious processes that I'm talking about, processes of the ego, become more conscious, cortical thinking. And of course, now I'm going to define magical thinking, which itself defines the final cluster A personality, and therefore our final prequel, which would be the schizotypal personality disorder. Right? Individuals with schizotypal do present with bizarre behavior and bizarre thinking. However, since they don't yet, and they don't always necessarily evolve to a psychotic disorder, but since they don't yet actually portray or demonstrate active psychosis, we don't diagnose them with an Axis 1 psychotic disorder. They are actually diagnosed with a personality disorder, but they're kind of in that gray area between a psychotic disorder like schizophrenia, which Donnie Darko, the movie, is about, and the schizoid personality, which still operates really at that subconscious level through these dynamic defenses, those processes of the ego, specifically fantasy. Right?
So if Donnie Darko thought that the bunny he saw had some kind of magical powers and some kind of magical abilities, would that kind of shift the narrative towards schizotypal?
Yes,
Okay.
yes. So, and perhaps Frank does, right? I mean, time travel. That's magical thinking. Right? It's also mathematically proven, but I mean, it's magical thinking in terms of this fictional movie. With that, why isn't this about schizotypal personality disorder? And the answer is it is, if we're willing to say that the bunny is not a true hallucination, and his belief in time travel and that the world is going to end, more importantly, is not a fixed belief, and therefore it's not a delusion. If we're willing to say that, then he's probably the schizotypal personality. Now, the other thing to remember here, and this I think is almost perfectly illustrated in the movie, is that while we talk about these personality disorders as discrete illnesses published in the DSM as prodromal, as risk factors of developing a psychotic disorder, rule out schizophrenia, and that is true, the continuum and the linear relationship, the temporality of this, is not as straightforward. Where someone actually stops having the schizotypal personality and now is diagnosed with schizophrenia is probably not going to be a date. It's probably going to be over a series of months, perhaps even years. And maybe we actually catch Donnie there. Because as a viewer, we don't know what we're seeing. Right? Is this bunny a product of his mind? And is Richard Kelly, not Richard Kelly, yeah, actually, is Richard Kelly trying to tell us about the subconscious processes of this troubled child? And if so, we're probably going to err more on the personality disorder side. Or is what we're seeing real life events, fictional life events, and straightforward and overt psychosis? And since we really don't know, it's subject to our perspective. Maybe we are in that liminal period over a series of months, if not years. Maybe that's why Kelly gives us that 28-day, plus timeline to suggest that there is this very special window that we're looking at where the clinician is not going to have a clear picture. What's going on? Is Donnie still prodromal, or is he now presenting with a first break psychosis? If you really wanted to clarify this, you would write the prequel. All right, the prequel, if you wanted to make it very discreet, give us the answer, that would be doable. But without it, here we are. All right, so that covered Frank as well. Any other thoughts about Donnie the character?
There's a lot of pretty explicit sexual fantasy and conversations, either with therapists or with friends afterwards. And I don't know at what point it becomes an adaptive process versus maladaptive and inhibiting his relationships in the movie.
All right, so I think to address that question, the clinician should always start off and have a starting point that it is normal until presented with evidence that it isn't. Right? Always give the person sitting across from you in your office the benefit of the doubt. And only when either they or collateral presents evidence to the contrary do you begin to enter the term of abnormality or abnormal behavior. Even if it's abnormal, there's still maybe nothing to do with regard to the psychiatrist. because the next step is to suggest whether that abnormal behavior is disordered behavior, meaning that there's some functional impairment now. What we can do, taking some liberty, is identify that at least one act of overt sexuality does appear to be dysfunctional, and that is what happens in the office. He actually begins to masturbate. However, having said that, he also was under hypnosis as well, and we don't know what role that actually played. Hypnosis, gets at right brain functioning and does get at behaviors, thoughts, memories that the individual does not have conscious control over. It's the whole idea, pardon the pun, of hypnosis. So, if we see Donnie do what he did, I'm not completely yet convinced that his being overtly or hypersexualized is problematic or dysfunctional. That's what Donnie. All right. Continuing on, what other characters do you think you'd like to discuss today through the psychiatrist lens?
Either do his girlfriend, Gretchen, or what was the name of, I think at the end of the movie when they raided like the office and found like the pornography for
Cunningham?
Yeah.
Cunningham.
So yeah, let's talk about him. I think his diagnosis is a bit straightforward. So what are we thinking about the inspirational speaker here?
Pedophilia?
Yeah, so that's that. So certainly we're looking at an abnormal behavior described as a sexual deviancy or paraphilia, specifically pedophilia, right? Where an individual actually has sex with someone who is prepubescent and is at least 2 years younger than they are. Now, let's take a step back a little bit, again, try to prepare you for an examination. In the DSM, prior to 2013, DSM-4, the sexual disorder chapter was broken down to 3 parts. In the DSM-5, the American Psychiatric Association determined that those 3 parts were going to become 3 separate chapters. So the first chapter is the sexual dysfunctions. We're not going to talk about that today. I don't think that's what's going on here in Donnie Darko. What I will suggest is that for purposes of studying, Google sexual response cycle, tap on images, and with that image of the sexual response cycle, open up your favorite board review text, and then review the different sexual dysfunctions. What you'll notice is that there is at least one sexual dysfunction for each part of the sexual response cycle. And I think studying that way will really help remember that for your exam. Another sexual disorder is a disorder called gender dysphoria. This is dysphoria or depression, which can be very severe with individuals who have a disconcordance with regard to their sex assignment at birth and their experienced gender. The third chapter are the paraphilias, otherwise the sexual deviancies. And this is Jim Cunningham. This we will talk about a little bit. And to talk about this, I need to know from you how you learned the planets. Do you recall how you were taught the planets?
Using a mnemonic.
Do you recall what it was?
We had to make them.
Really?
Yeah, in class. I think mine was
Let's do this.
Miss Victoria. Oh gosh, well, no. There's something about Miss Victoria calculating a math journal pattern using, or a journal pattern. I don't know, something on a pattern with the right order of the planets.
Wow.
I don't remember.
All right, that's interesting. Miss
Miss
Victoria.
Victoria estimated.
Estimate, yeah, calculator
Yeah.
doesn't work.
Estimated a sum using a natural pattern.
I love it, I love it.
I
How,
just had to Google it. Because like once you said, like I had no idea. I was like just going through the planets, and then once you said that you're the sign of mnemonic, I was like, look up mnemonics.
What do you got?
I found the one. My very educated mother just served us 9 pizzas.
that's the most common one I hear from medical students. We have to talk later, right? I think this is awesome. Yes, I've heard that over 100 times. Again, maybe a little bit of variance, but that's a very popular one, over 100 times. It always begs the question, what about your very educated father? Nobody ever talks about the very educated father. So I have another acronym for you. My very educated father surfs porn for thrills. Now write that one down. Don't Google it. Do not Google it. Write that down, right? Because once you understand that acronym, you will now remember all the paraphilias. All right? Let's go in order. My very educated father, M. Masochism. Now, for all these paraphilias, there are things that are inherent that you have to remember, both as a clinical pearl and for test-taking purposes, and they apply to all of the above. Right? So I'll probably restate them once or twice, but they apply all of the above, and so as not to have to repeat them every time. You should know that when we actually identify the deviant behavior, that behavior must always be performed for sexual gratification. If it's performed for any other reason, it is not a paraphilia. The other thing about this is that we make a differentiation between, in this case, masochism, M, and masochistic disorder. And that was a nuance, that was an edit that was put in the DSM-5. Masochism is an abnormal behavior. And when that abnormal behavior called masochism is clinically significant, when it results in clinical impairment, we then say it's a masochistic disorder. And that applies again to the entire acronym, masochism. All right, so given that, anybody have any guesses what masochism is? What's the behavior we're identifying here?
Enjoying pain. Finding pain arousing.
Right, enjoying pain, will apply for sexual gratification, and when clinically significant, we have masochism or masochistic disorder. V,
Voyeurism.
what's the behavior in voyeurism?
The use of, again, seeing another either person in a sexually arousing state,
Yep.
unbeknownst to them.
Exactly right.
Their own arousal.
Yep, exactly right. All right. E, educated.
Exhibitionism.
Good. What's the behavior?
The inverse of voyeurism.
Which is?
Enjoying performing sexual acts with an audience that didn't agree to it.
Good. Right.
With a
So,
non-consenting audience.
non-consenting, unsuspecting. Right.
Is it also exposing?
Yes. Exactly right. F, father.
Yes, fetishism.
Good. Fetish. What is it?
Counts for,
Broad category.
Yeah.
Like finding random objects arousable for the person.
Is it always an inanimate object?
No, it could be a body part. Good. By the way, for fetish, that does not include objects that are marketed for such reasons, right? So there's no such thing as a vibrator fetish, right?
So does it always have to refer to like a physical object, or
I believe so.
okay?
I don't think the word physical is actually in print in the DSM, but I do think that's intended.
Fun neuro fact. The reason that foot fetishes are the most common is because of where the feet and the genitals are located in the homunculus. Because they're very close neighbors, it's easy for the wires to get come across.
Interesting. Is there any functional MRI studies with that?
Not that I'm aware of.
Right, because you'd have to get people in that fMRI and introduce either imagery or allow them guided imagery and see what it lights up. That'll be interesting. That'll be really interesting. Serves porn for thrills. S.
Sadism.
Sadism. What is sadism?
Inverse of masochism. Enjoying inflicting pain on others.
Perfect. P. Jim Cunningham. Pedophilia. F. Frauderism. What's frauderism?
So the act of placing either your genitals or I guess some other body part unsuspecting or unwanted from another party as a way to gratify sexual.
Not other body part, though.
Oh,
General.
it's just general. Okay.
Yep. And then T. T's always the toughest one to remember. It's transvestic fetish. So if you want in the acronym, flip the two F's the way in the order that we describe them. Have fetish be second to last, and then that hopefully will remind you that the T is actually a specific type of fetish that is so common that the DSM gave it its own label, which is transvestic fetish, when the actual fetish object is the clothes of the other sex.
It's clothes, you said, correct?
Close.
Okay.
Yeah. All right, so there's your acronym, and that allows for us to remember our differential diagnosis, but I think in this case, the single best diagnosis for Jim Cunningham is rather straightforward, right? Pedophilia. Any other thing you want to discuss about Jim Cunningham?
His role as a motivational speaker in high school.
Mm-hmm. What about it?
Well, it seems like not a great location for somebody who's trying to avoid acting on pedophilic impulses.
So not likely registered. It couldn't be registered, right? In sex offender registry.
Oh, I see what you mean.
Yeah. Which
I thought you meant,
means
psychologically registered.
no. Yeah, I mean, we think that he's not going to be in the registry,
Right.
which means that he hasn't been caught.
Right.
Which means that what we see as his behavior appears for him to have been working probably for several years, right? So that really gets to some insight as to who this person is. He's been able to manipulate people the way he's manipulating this gym teacher for several years, because I think there's evidence that he obviously hasn't been caught. And I don't think he's even been caught and released, because otherwise he would have been in the sex registry, and that should not be the case. Should not, if he's working with high schools. Right, so maybe even more personality traits than beyond pedophilia, although sexual predators certainly do develop a personality to ensure that they meet their one and only goal, and that is to prey. And that even may be without a formal diagnosis of the antisocial personality disorder. That is predatory behavior.
I've read that one of the difficulties, so I've read that we don't currently have great therapies for people with pedophilia, and one of the barriers to that is it's so difficult to study, because when somebody makes these urges known to a psychiatrist, I think we have a legal duty to report, which kind of means that then the therapeutic alliance is out the window, and it's kind of impossible to then study treatment. What are your thoughts on that?
So, duty to report's difficult here. If an individual is saying they have the urge, there probably isn't anything to do. Certainly, if as a clinician you feel there is risk of the individual acting on the urge, that's a little different. But nonetheless, to your point, it is very difficult to study. Ironically, of all the paraphilias, pedophilia is the one that likely has a published incidence that is closest to the real world incidence, whereas the others don't, right? And that's because of these individuals actually coming to law cases, to cases within the law, right? That is, when they're caught, they're on record, and that's usually not the case for the others. They're usually not caught. So this is actually a crime that's taken much more seriously than the other paraphilias, right or wrong, and therefore, what is reported to be the incidence, while still an underestimate, at least approaches the real world incidence, and you can't say that for any other of these paraphilias or paraphilic disorders, right? Nonetheless, to your point, the same applies. It is still significantly underrepresented, and a lot of it has to do with exactly what you're describing, and that is individuals like this simply are not likely to disclose what their thoughts are for multiple reasons, not the least of which is the legality of it.
And so our duty to report would be if they have a plan or if we have a high index of suspicion.
Yeah, that a plan is in place, but your patient is minimizing or there's evidence that they're lying to you.
And Dr. Toby, did you mention that patients with pedophilia often have personality disorder?
So again, because we don't know the incidence, the true incidence of pedophilia, it's hard to actually state the true incidence of a co-occurring diagnosis with pedophilia. Having said that, if you look at sexual offender units, there is a very high comorbidity with the antisocial personality disorder. Now, philosophically, we can debate that because there may be traits of pedophilia itself that overlap with the antisocial personality, and perhaps it's not a true co-occurring disorder. It's part of the parasite's lifestyle. Individuals with this condition really have one goal, right? And that's the prey. Right? That's to be a predator. So, yes, antisocial traits, depending on whether or not you think there's true comorbidity, is one of perspective. Right now, the perspective in the way the DSM is written is with the co-occurring diagnosis. Anything else about cutting hair?
Like you said, I think before that he had the gym teacher under maybe his spell because she wanted to come to his defense, I guess in trial, when they found his pornography collection. So
that is wild to me. So that makes me think of how Ted Bundy, when he was on trial in Florida, I think it was his then ex-girlfriend who had made the initial phone call to tell police, like, hello, I think that's my boyfriend. She married him, like, during the trial because that was legal in Florida. That is its own.
It is. Parasitic lifestyle charisma is part of the diagnosis of not only antisocial personality disorder, but even more importantly, the psychopath. But again, whether or not there is true psychopathy or whether individuals who are sexual predators automatically are, or incorporate psychopathy, it's a matter of perspective. But yes, that's unfortunately way too common. And Bundy's a great example. There are multiple other serial killers who have been proposed to. I mean, Manson, and married while on death row, while in jail. Manson wasn't on death row, but imprisoned.
And what is your take on that?
So again, the charisma is a very salient feature and personality trait of the psychopath, of the antisocial personality disorder, and therefore even the pedophile, right? And there is a subconscious dynamic that occurs, and we get to this when we talk about the personality disorders, but it's probably good to bring this up here, especially since we just talked, well, we can talk about it, but we mentioned Gone Girl on Rounds today. Gone Girl itself is a fictional case of somebody with the antisocial personality disorder, right? Along those lines, One of the things that we see, and it's somewhat common in clinical practice, it doesn't always hold true, is that individuals with this condition, call it antisocial personality disorder, call it psychopathy, and we'll talk about the difference there. One is an actual illness, the other one is a clinical term. And there's a little bit of a difference. But that said, people with these conditions may have a subconscious reaction from opposite sex individuals that are caring for them, whether it's a psychiatrist, a therapist, etc. So it's a little bit of a red flag when somebody who has, let's say, is in fact a psychopath, and we'll say she's right here, and we have two opposite sex clinicians providing an in-depth psychiatric evaluation for the court, right? When the two clinicians leave the room after that hour and present to their attending physicians, the same-sex clinician may actually tell you that she didn't like her. No, she troubled me. I wouldn't turn my back on her. I don't like her. Right? While the opposite sex clinician may actually say, you know what, charismatic, attractive in her own way. When the attending physician, the mentor, the supervisor, hears that type of report from opposite sex clinicians, the antisocial personality disorder and the psychopath have to enter into the discussion. And the same is in Gone Girl. I mean, if you look at a fictional case, i.e. a movie, some women may come out of that movie saying, I did not like that character, Amy. Whereas some men might come out and say, amazing. Wow, amazing. Right? And it doesn't always happen, but when it does, and it happens more often when compared to other personality disorders, when it does, you've got to think the antisocial personality disorder. Another movie, I love mentioning this one, is Kill Bill. Right? I mean, the main character there, a lot of women that I talk to just think the movie was okay. A lot of men just absolutely say it's Tarantino's best. Right? Loved it. 88 Yakuza in about 13 minutes. Right? There were little body parts on the floor. There was so much blood in that movie that in order to not get an X rating, they had to go back, take out scenes, and edit in cartoons. That's why there was the cartoon edits in there. Right? Awesomeness. Right? So individuals who watch a film where a character is a psychopath can have a very similar reaction to a real-life psychiatric evaluation where they're interviewing one. So something to think about.
Related to this point, so I know we talked a lot about the unconscious or subconscious reactions, but what do you think about like the learned traits of an antisocial personality or like a psychopath? Like the way they learn how to charm or skills necessary in order to hide this pathology? So
anytime we look at human behavior in general, we always have to think not only biopsychosocially, but along the 3 Ps, right? So predisposing, precipitating, perpetuating. So what we do know is that there does appear to be functional MRI studies that show individuals with this condition called psychopathy have lower volume of their cerebellum. And therefore, it has been found through staining that the mirror neurons seem to not develop normally. That would be not only a predisposing element to what is called psychopathy, but more specifically, a biological predisposing element, right? So from that, we can begin to formulate psychopathic behavior or the antisocial personality disorder. If an individual were to charm someone, and this may be a random thing, and it results in an outcome that is favorable for them, like Ted Bundy does get that person in the back of his van, right, by being charming, by acting as if he's injured, and gets her assistance, gets her pity and sympathy, and all of a sudden she's in the back of a van heading somewhere. That means that the charm and the charisma worked. So now we take a biological predisposer, and now we're looking at what perpetuates the behavior, and we can now look at another perspective, psychological perspective, specifically that the charm worked. The superficial charm was actually successful and therefore was positively reinforced and is then going to be strengthened. So now we're adding in behavioral principles of operant conditioning in this as well, right? So a lot of things to talk about here with regard to serial abductions, serial killing, serial killers. But that certainly, I think, addresses your question, and we could address it at any stage: predisposing, precipitating, perpetuating, all biopsychosocial factors along the way. Before we end this discussion, I do want to owe a couple of minutes to Gretchen. My favorite question, you are off camera, my favorite question, and you only could give one word answer here, and that one word can either be yes or no. Did you like her? We're going to go around the room so everybody's fair game. I'm going to start to my right. Did you like Gretchen? Yes or no? Yes.
No.
No. No. And no. Well, you're actually in the minority saying yes. All right. Any insight as to why anyone did not like her? You're off the hook.
Yeah.
What turns you off? By the way, saying you didn't like someone in a therapeutic milieu is perfectly appropriate. And in psychiatry, it's called countertransference. Now, countertransference can both be positive and negative. One of the more difficult parts of the training, the resident training in psychiatry, is to unlearn those things that your parents taught you, which is that it's not nice to dislike someone. In a therapeutic milieu, in a clinical milieu, it's important to be faithful to your feelings because it could help in the diagnosis. You may have tapped into something here at a subconscious level. Right? So if you dislike someone like you do, Gretchen, it is not okay to tell her to get out of your office and that you don't want to see her. You're going to find that's not what this is about. This is a therapeutic maneuver, and it's not unlike getting a fasting blood sugar or a quick AccuCheck on someone that you may think is hypoglycemic. Very similar, right? So you tapped into something here. Now, when this happens in therapy, you will go to your mentor, your supervisor. You'll discuss your countertransference and your feelings of dislike towards this patient named Gretchen. And it's in that process, in that supervision, that you may uncover something that will be a breakthrough in therapy and can be a cure for her. So good job on being true to your feelings, but now we have to kind of process this. Any guess as to what you tapped into? You tapped into the. Oh, sorry, go ahead.
Just it might be just like my personal or just like my bias tapping in too, but I feel like it's kind of like helplessness, kind of like if the character were to take charge. And I mean, might have to just be with the plot, but I think if it has to do with like helplessness of the character, and I feel like if the character is able to take charge of the situation, I think that's more favorable. Like for me, I think that's more, what's the word? I feel like if you take that kind of stance, it's more independent, and you're able to help yourself, kind of.
So she did not come off to you as being empowered?
Right.
Right? And you thought that perhaps she had the resources to gain that, but for some reason, something was preventing her. And you put that on her.
Right. Okay. It might not be fair for her.
Oh, well, again, whether it's fair or not, that's your feeling, right?
Yeah.
Any other thoughts?
I want to second that and also say that, like, the conditions under which she did kiss Donnie Darko, like, first she didn't want to, and then it was only when she was in tears and had just been bullied that she did. And so it seems that in spite of having seen that relying on a man as a crutch, like, has not worked out for her mom, that is what has been modeled for her. And I like a strong woman.
That's fair. The other thing, again, this idea of countertransference is a subconscious process. So what we're discussing now is insightful, but only after hours of psychotherapy supervision do you even begin to tap in to really what's going on. So this is the initial part of that discussion. I'm going to give you the final answer here, though, because it is actually contained in the director's cut. What you tapped into without even knowing it is that this is a case of malingering. That everything that this character said, everything that this character did is a lie. It's an absolute lie. Her father did not abuse her. Her father is not away. Her father is not trying to find them. She doesn't have any signs of post-traumatic stress disorder. Her family is not in a situation that she tells Donnie it is in. She doesn't like Donnie. She doesn't find him attractive. She doesn't want to be his friend. All of it's a lie. It's all in the director's cut. Now, the way this character goes ahead and then presents herself the way she does is a little bit incongruent with her real motivation. And you tapped into that without even knowing it. Right? We're going to stop here with the final diagnosis of Gretchen of malingering. That is, there is a conscious effort to deceive, the motivation of which is also externally incentivized. And that external incentive, I should say, not incentivized, that external incentivized, is saving the world, saving her life. We'll get to more of that a little later on, off camera, off that podcast, but that's exactly what you were tapping into.
I'll say it's interesting you describe it that way, because when you had said that, I'd seen the movie a couple years ago, but the whole idea of like this helplessness piece that you were describing, especially, I remember like on first watching, like thinking like you want to take care of this person, like this person seems helpless, and like I suddenly feel like as we're talking about all this stuff, I'm buying into the whole storyline, and now you give us this whole perspective of everything that's happening in the background with the director's cut, and I'm like, I wonder if this is the antisocial personality trait, like just playing out again.
Yeah.
Because like I felt like again like wanting to take care of this person. And
Exactly right, and that's exactly the way she needed Donnie to feel, because only then can she set him up the way she did to do what he did and sacrifice his own life to save hers. Malingering.
Would you say Gretchen is like the main character from Gone Girl then?
Well, I mean, in as much as Amazing Amy malingers, yeah. I mean, it's the same diagnosis. Amazing Amy, again, feigns illness, blunt force trauma, feigns illness, well, not illness, feigns a pregnancy, and the incentive is external. So both have the same Axis 1 pathology, although the DSM-5 changed things a little bit, but they have the same mental disorder called malingering. Again, this is differentiated from a condition called factitious disorder. That is also when someone or lies, misrepresents themselves, but their motivation is subconscious. So the motivation behind it differentiates malingering, conscious, external incentive, versus factitious, unconscious, subconscious. Hers is external, right? That's the end of the movie. We'll leave it there, and I will tweet next week's movie discussion. We will be back. We'll come back on Periscope in just a little bit.